Good morning. So we will start with chronic kidney diseases. Chronic kidney diseases. This is majorly a PG topic, but we will start with the basics. So it is basically due to decrease in number of nephrons. Decrease in number of nephrons occur due to any abnormal kidney function or progressive decline in GFR. GFR, we know, glomerular filtration rate. Overall kidney GFR is equal to GFR of one nephron multiplied by number of total nephrons. Kidney diseases are mostly characterized by 80% they are due to interstitial fibrosis. Followed by glomerulosclerosis. And lastly, tubular atrophy. In short form, they are known as IF, IFTRA. Kidney diseases starts with hyperfiltration. Kidney diseases starts with hyperfiltration. Hyperfiltration leads to proteinuria, which is a major hallmark of all the kidney diseases. Proteinuria. Excessive proteinuria causes tubular toxic environment, which leads to interstitial inflammation, there is a release of TGF beta, we have to remember two things, proteinuria and this TGF beta. And this finally results in fibrosis. So this is basic pathology of chronic kidney diseases, which starts with hyperfiltration, which causes proteinuria, and excessive proteinuria causes tubular toxicity. Tubular toxicity leads to interstitial inflammation, which causes release of TGF beta, and this TGF beta leads to fibrosis. Acute kidney diseases last from hours to days. Hours to days. And here we are talking about chronic kidney diseases which last for more than 3 months. More than 3 months. The physical changes in the shape of kidney in chronic kidney diseases is first corticomedullary reduction. Corticomedullary reduction between 8 to 10 centimeter, or kidney size reduce to less than 8 centimeter, or kidney size more than 10 centimeter in HIV, diabetic, or amyloid patients. For chronic kidney diseases, GFR value less than 60 ml per minute is a sign of concern. Anything above 60 ml is normal. Along with GFR, there is another important value, which is albumin creatinine ratio. A for albumin, so creatinine ratio. The value of this is anything above 30 mg is a sign of concern. More than 30 mg is a sign of concern. For GFR, anything below 60 ml per minute is a sign of concern. And for albumin creatinine ratio, anything above 30 mg is a sign of concern. On the basis of GFR value, we will stage the kidney disease progression: G1, G2, G3, A, and G3, B. G4 and G5. For G1, the value of GFR is more than 90 ml per minute. As I told you, less than 60 ml per minute is a sign of concern. So for this, it is basically low risk. For G2, it is between 60 to 90 ml per minute, which is again low risk. For G3A, the value is between 45 to 60 ml per minute, which is moderately risky. For G3B, it is 30 to 45 ml per minute, which is high risk. For G4, the value is between 15 to 29 ml per minute. This is very high risk. And for G5, it is lower than 50 ml per minute. Now we will discuss causes of chronic kidney diseases. So the most common cause is diabetic nephropathy. This is most common cause, but it has the worst prognosis. But it has the worst prognosis. Second, autosomal dominant polycystic kidney, which is the least common cause, but it has the best prognosis. This is least common, but it has best prognosis. As I told you, tubular interstitium injury. Wait, I'll write it with different color. Tubular interstitium and sclerosis are the determinants of the intensity of the injury. As I told you before, 80% involvement in chronic kidney disease is of interstitial fibrosis, second, glomerular sclerosis, and third, it is tubular atrophy. But 80% it is the fibrosis, which is taken into consideration to check the intensity of the injury. Decrease of nephrons leads to hyperinfiltration, which leads to proteinuria. Proteinuria causes tubulotoxicity, which causes interstitial inflammation, which causes the release of TGF beta, and that leads to fibrosis of the kidney. Now, in brief, I will tell you about the mechanism of a chronic kidney disease. The single most risk factor is proteinuria. Loss of nephron is associated with hypertension. Loss of nephron causes hypertension, which causes stretching of the glomerular capillary wall. Stretching of glomerular capillary wall. This impairs filtration. So here, due to stretching of capillary wall, this results in impairment of filtration. Due to impairment of filtration, as a part of mechanical strain, angiotensin II is produced. So here, angiotensin II is produced. This angiotensin II is expressed on podocyte. This production of angiotensin II downregulates the nephrin expression and hence causes proteinuria. This downregulates protein expression, which leads to proteinuria. And proteinuria, as I told you, is the single most strongest risk factor for CKD. I will give you some more knowledge about the podocyte response. As there is impairment of filtration due to stretching of the capillary wall, angiotensin II is produced, which is expressed on the podocytes. In response, on podocytes, there is loss of effacement process, and loss of slit diaphragm. which causes release of ET1, endothelin 1. This endothelin 1 causes alteration in the structure and function of the podocytes. ET1 causes alteration in structure and function of podocytes. TGF beta is also released here, which causes fibrosis. As I told you before, TGF beta leads to fibrosis. To reduce the expression of endothelin 1, we can use ED1 blockers, and for hypertension, to reduce it, we can use calcium channel blockers. About more specific drugs, we will study in the next lecture. Thank you.